Well, thank you very much, Dr. Bott. It's certainly a pleasure to be here. I'll touch on, I don't know if calcium is my top 10, but I'll certainly touch on that at the end if I remember. These are my disclosures. I reached out to my colleagues in other imaging areas. I'm not an expert in all things cardiac imaging, but I reached out to some of the past presidents of the different societies and got some of their top ideas as well. I'll do it backwards from what Dr. Martin presented, and I'll start with number 10 and work up to what I think is the most significant advances. But we heard a lot about artificial intelligence already this morning, and certainly it's going to help us in, I think, raising the bar to at least a moderate level. So I think AI for imaging helps the people who are the least empowered. So, and you saw that as well with the errors that was pointed out by Dr. Rich in the first talk. The experts probably derive less benefit from AI, and the novices derive more benefit. But for something like Echo, where there's a broad range of readers, it really can raise the bar quite a bit. And there are now some very powerful AI tools to help us read Echo. And it's not just improving the interpretability, but improving the image quality, helping the techs acquire better images, and real-time AI feedback to improve time. So it enables care teams to expand capacity. It really, I think, importantly adds higher quality diagnostic images to any technologist. It'll improve their ability to acquire images, and I think it'll speed up and maybe improve interpretation and reporting capabilities. We don't really have great proof of concept yet that I've been able to find, but in this one paper, it did reduce quantification time by 51% for the readers. It saved 82% of time for acquisition and analysis by the technologists, and it did reduce the echo exam time by 20%. So I think acquiring data faster and maybe more on a level playing field will be helpful. Moving on to number 9, this is called FAPI. It's used for myocardial fibrosis. I think you'll hear a lot about fibrosis, maybe even in the talk on hypertension. We're talking about new agents that might help us with fibrosis. But FAPI, it looks at fibroblast activation protein inhibition. It's done with a PET scanner. So you can now look for activated fibroblasts in the myocardium. So this is going to be helpful for fibrosis of the myocardium. It's going to be helpful for remodeling and really targeting many chronic diseases. So we're going to have it potentially be helpful in post-MI infarction for who's at risk of remodeling. It's going to help us, I think, with hypertrophic cardiomyopathy. It certainly has a role in heart failure, and it might even help us direct which drugs to use. If we have drugs that are good for fibrosis, there are some of the newer things like the non-steroidal aldosterone agents that might have some anti-fibrotic activities that might be helpful. And the extent of the FAPI index, or the more fibroblast activation that we see, correlates with disease severity and risk of sudden death. And this is just a pretty picture showing on the left, you can see the uptake of this in a patient with dilated cardiomyopathy and the potential use of this to identify patients at higher risk or more active disease. Number 8 is, I think, still being utilized a lot, maybe not quite as novel, but I think I'll show you some interesting new data. But FFR CT, or fractional flow reserve estimated from a CT angiogram, anatomical testing, I think, is where we're headed for a lot of first-line diagnostic testing. It's certainly more accurate than functional testing as far as who has obstructive disease, and for the interventionalists who might need intervention, but we lose something if we don't have functional anatomy or physiology, and that is we don't understand which lesions are physiologically significant. And I read a lot of cardiac CT, and I see a lot of moderate and even some severe disease, and not all of those lesions definitely need revascularization. So if we can guide not only in whom may need revascularization, but which vessels may need revascularization, that might really help us target different therapies and different approaches to revascularization. So with FFRCT, we can now model, again using AI, we can now model which vessels have physiologic significance, and red is bad, is lower flow. This has been highly validated against invasive FFR, and you can see that it really helps us in deriving which lesion might be most amenable to revascularization or where those lesions are. It does raise our accuracy as well for when we use FFR invasive fractional flow reserve as our gold standard, and this was the Pacific study. They looked at a SPECT in orange, not very accurate for physiologically significant lesions. It had an AUC of 0.7, so think about 70% accurate, not great. Both sensitivity and specificity were suboptimal. CT angiography and PET both did better. They were in the low 80s. And then FFR-CT really raised the bar and raised the area under the curve to 0.94. So really highly correlated the physiological lesions that we saw invasively with the non-invasive imaging modality. Number 7 is four-dimensional flow now with cardiac MRI, really providing a comprehensive and dynamic view of the heart and the aorta. It can look at blood flow patterns. It measures velocity. It quantifies hemodynamic parameters like shear wall stress. And it's really useful, I think, for more complex conditions, including aortic diseases, but planning surgery and monitoring diseases more accurately than traditional measures. So here's a nice example of an aorta with four-dimensional imaging. I don't have a movie to play you, but this would show the flow patterns and hopefully help plan out who might need intervention earlier. We can use it in heart failure. This is, again, an opportunity to look at both flow and regurgitation in a more accurate way. And finally, I think very interestingly, we can look at not only ejection fractions and flow, but we can look at residual volumes and delayed ejection flow and hopefully help target therapies a little bit better. So four-dimensional MRI giving us a little bit more information without extra imaging. Number 6 is our echocardiographic imaging to guide tricuspid interventions, or what we call TEER or TTVR. So echocardiography has really advanced our evaluation of the tricuspid valve, and as you know, kind of the last of the big valve domains that we're tackling now in cardiology. But the aims of the pre-procedural transesophageal echo now in a patient who needs tricuspid valve repair is going to be to quantify the tricuspid regurg severity. We're going to look at the leaflet morphology and anatomical variations, assess annular and adjacent anatomy, which is going to help, I think, with targeting which approach is better. And really, I think, helping the interventionalist with both the potential adverse features, but also what approach may be safest and best for the patient. Again, just looking at examples of some tricuspid valve interventions with clips, very easy to see on transesophageal echo. Sometimes intracardiac echo can also be used, or ICE. But I think looking at the different valve lesions and looking at the interventions, both pre and peri-procedural, is going to be very helpful. So for peri-procedural guidance, echo will help us with real-time images to guide the delivery of the catheter and the device. It really ensures that there's optimal placement, looking at opposing leaflets and placing new valves. As far as 3D imaging and ICE, definitely as an adjunct to transesophageal echo for difficult cases, helping confirm leaflet grasping and device placement. And of course, I think most importantly, hopefully, looking for things like shadowing and other things that may interfere with device placement to really hopefully help guide the intervention. Back to MRI for number 5, we have quantitative myocardial perfusion. This is now really looking at the ability to look at blood flow to the heart muscle, which was previously only available by PET scanning. So now MRI is moving into the PET domain. So, back in the day when I was doing cardiac CT in the early days, we had this battle between CT and MRI as the two advanced imaging modalities, kind of trying to establish a role against the nuclear and stress echo world. Now it's really MRI and PET kind of battling it out for some of these more less used or less common problems. But I think when we talk about coronary microvascular dysfunction and we start thinking about things like ANOCA and MINOCA, I think really understanding myocardial blood flow to help diagnose conditions like this, to look at accurate and objective analysis, is really going to be helpful for us to help quantify these diseases and identify perhaps those men and women who are suffering with non-obstructive disease who have ischemic burden. It's been adopted in the newest guidelines by the Society of Cardiovascular MR. This is their expert consensus document and really has put forth this concept that CMR is at least as accurate in the detection of obstructive disease as PET, and provides more accurate estimation of the total ischemic burden in patients with coronary disease. Again, both are good, but again, ANOCA, MINOCA might be a special role for MR and quantitative myocardial perfusion. We can really see clearly the utility of this in microvascular disease. This is a stress MR, and you can look at the bullseye target, and the numbers have gotten worse, implying that there is microvascular disease that's affecting myocardial blood flow during exercise. Another MR advancement, this is kind of a unique one, but I think it's pretty interesting, is using non-contrast studies. So taking two non-contrast MRs, or basically an MR with two different modalities, without giving gadolinium or any other enhancing agent, and emulating contrast-enhanced imaging. Gadolinium, as you may know, has some toxicity, especially in renal disease, but it's very costly, and it does slow down the procedure quite a bit. So if we could use what they call virtual native enhancement, or using MRI, non-enhanced images, to give us pretty pictures that emulate contrast enhancement, I think would really go a long way towards making MRI a more useful tool. It's very time consuming, it's very hard to do, and when we start adding contrast, it makes the procedure both harder and a little bit more expensive. So it uses two different images, pools them together, using a T1 mapping program as well as cine images, and then it pools them together to give us what's called virtual native enhancement imaging, again using AI to kind of combine the two images into one. So there's no contrast required. This virtual native enhancement eliminates the need for gadolinium-based contrast agents. It's faster and cheaper than using contrast-enhanced studies, and at least some of the studies report superior image quality compared to conventional gadolinium scans. These are a couple examples that were published recently. You can see on the left in each column is the virtual native, and on the second column is the late gadolinium enhancement. So this is with contrast, and you can see that they look, at least these examples look fairly similar, even though there's no contrast given in the green VNE columns. So we are getting better at now emulating contrast, which I think for MRI is going to be an important aspect. Number three goes back to cardiac CT. Plaque imaging, I think, has come a long way, and we touched on coronary calcium scanning. I think when we start talking about CT angiography, if we're going to use this tool, especially maybe useful in the younger patients, now that the radiation doses are low, I think Dr. Fuster's correct, we can't use coronary calcium probably below the age of 40 for sure. In most patients, it's just not going to show up. I think it dominates as people get older. It's a better tool, but I think early on we might use AI and CT to quantify plaque. Patients like a number. They want to know what their calcium score is. When I do a calcium score with a CT angiogram, and the CT angiogram shows no obstructive disease, but their calcium score is high, all they want to talk about is the calcium score because they like the numbers. We've taught them numbers, right? Dr. Martin's taught them to know their LDL, and the endocrinologists have taught them to know their A1C, and the blood pressure experts have taught them to know their blood pressure. So they want to know their score. Well, with a CT angio, we weren't able to give them a score. So the calcium score was their number. But now we can start quantifying plaque, and we can get total plaque volumes, and you can see this was from Scott Hart. In blue is a high total plaque volume. In yellow is a low total plaque volume, and it predicted risk really well. 7-fold hazard ratio. It's a really robust number, much higher than what we see so far with biomarkers or polygenic risk scores. On the right, if we look at just low attenuation plaque, or what we call necrotic core, you can see again, highly predictive and additive to what we learn from plaque imaging. So we can use these AI tools to quantify plaque. But I think we can go beyond that now. Again, we have calcium score, and there's actually some nice AI algorithms to look at the calcium score more than just the original, what we call the Agatston score, to derive density, location, even the morphology of the calcium to help us predict who's going to have more events. And then we can use the CT angio-derived AI QCT, this quantitative CT plaque volume, to get things like percent atheromal volume, as well as non-calcified plaque volume and low attenuation plaque. And all of those improve the area under the curve significantly. And as we start looking at these additional metrics that we can derive from CT, it improves upon risk factors. It then improves upon risk factors plus calcium scoring, and even upon risk factors plus calcium scoring plus PAV. There was a nice study that was done by the CONFIRM group, which I'm a part of at the European Society of Cardiology as a late-breaking clinical trial. We looked at AIQCT and looked at risk stratification, and it improved the area under the curve compared to CAD-RADS, which is just how much percent stenosis they have. It improved the area under the curve compared to the coronary calcium score, and it improved the area under the curve compared to the Duke index. But I think as we talk about combining these AI tools, we have to put them all together, right? If I'm going to use a CT angiogram and I'm going to give patients contrast and I'm going to spend whatever those dollars are for that study, I want to derive the most information. And I think we're now learning how we can combine these FFR tools. Is there a flow limitation? And is there a lot of plaque? So this was a really nice study done, a 3-year follow-up called Advanced DK. It was published in JACC a couple of years ago now, but I think this is the concept that's very prevalent in our treatment algorithms. For these patients who had no flow limitations, their FFR-CT was negative. Their flow down the coronary was normal, but they had a lot of plaque. They're in the top quartile for plaque quantification. They had late events. They had events years 2, years 3, so we have time to intervene. And with all the new things that we just learned from Dr. Martin and more that we're going to learn later today, there's a lot of interventions that we can apply. If somebody has atherosclerosis, we now have time to intervene. But what happens if their FFR is abnormal? There's actually some really nice studies that show if you don't intervene on FFR-CT and don't completely revascularize, patients have more events. So while we can talk about the accolades or the failures of the ischemia trial and whether or not we buy into the fact that we can't risk stratify by global ischemia with functional testing, which I believe we can't, I think vessel-specific ischemia is going to really help guide us in who needs to be revascularized. And this is where we start seeing early events. So if you have a positive FFR-CT, but not a lot of plaque, your events all occur early, and that's where we want to potentially intervene. And again, there's now 3 studies that show if you completely revascularize based on the CT, FFR-CT, so the CT-based FFR, that you can bring events down to the same level as patients who have no abnormal flow in their coronary arteries. So you can reduce their risk if we target vessel-specific ischemia. And maybe we'll get Dr. Bott's thoughts on that in a moment. But abnormal events occur in those patients who have abnormal FFR CT, and those events occur early. But then if you have both FFR CT abnormal and a lot of plaque, you end up with a huge a huge event rate, because now you have early events and late events. Moving on to number 2, we have another PET discovery, which is fluoropyridinase, or should be able to say that better, I apologize, but a new tracer that's improving our ability to look at proportional blood flow. So it's probably better for obstructive disease, but most importantly, it has a long half-life, so it can be used for exercise, and it provides it's provided in a unit dose, so we don't need to have a cyclotron or generator on site to make this isotope. So this 18F-FDG uses a glucose analog to look at how the heart muscle is metabolizing glucose. So again, long half-life, can be used for exercise, and doesn't require a cyclotron or generator to create. And it can really help us with healthy tissue, scar tissue, and hibernating myocardium in a much more accurate way, because it's not looking at just blood flow like our previous PET tracers, like rubidium or ammonia. It's now looking at metabolizing glucose. And you can see beautiful uptake. This is combining it with treadmill testing. This was a study by Dan Berman's group in Cedars-Sinai. And you can see beautiful, beautiful uptake of contrast, and more uptake with exercise. So again, identifying that hibernating myocardium. So it's going to help us with viability, it's going to help us with scar, and it's going to help us with hibernating myocardium, and making, I think, PET much more useful, again, without needing a rubidium generator. But I think the number one advance, at least in the last year or two, is going to be photon counting CT. Photon counting CT improves the resolution of the images dramatically for cardiac CT. You can see on the top a previous iteration. You can see how the line pairs, how the resolution, and when you take the same picture with a photon counter, you can just see things much more clearly. It literally doubles our resolution and reduces radiation exposure, because it's much more efficient at looking at each photon as it goes through the detector, rather than eliminating a lot of the scatter issues. So it improves resolution. The image quality is much better. Anybody who's looked at any CTs will tell you that these images are most commonly dramatic. Obviously, any image can be good or bad, but really dramatic images, allowing us to overcome the 3 biggest limitations that we have with cardiac CT. So cardiac CT angiography, significantly limited by calcification. We can now have less blooming artifact and see calcified plaques better. You can see that in these images here, in very densely calcified plaque, but you can see now that lumen is still open in picture C. We can look at the evolution and look at spatial resolution. Our second limitation is on smaller vessels, or on seeing the vessel with higher resolution. And you can go from the 64 slice CT to the middle picture is a 256, and on the right is a photon counting scanner photo. And you can really see not only the vessel more clearly, but the side branches and the smaller vessels, as it doubles our spatial resolution. So we're going to see, again, densely calcified. There's a patient with an Atkinson score of over 4,000. And you can now see very clearly that this is non-obstructive in the right coronary. Picture C might show it the best, where you can just see the contrast going right through that calcified plaque. And the biggest advance will be with stents, and being able to accurately evaluate the stented patient. Calcium, causes a blooming artifact, metal causes a blooming artifact, and photon counting really reduces this quite a bit. And we can now see, with higher resolution and less artifact, we can look through the stent. So I'll leave you with that thought and just this process as we've gone through evolution with imaging and my path. All truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. And third, it's accepted as being self-evident. And I think we're starting to get there. So thank you very much.
Really terrific talk. Any questions, please go ahead and use the Slido. Maybe I will take this time to come back to that question of the coronary artery calcium of 0. What does that mean? What does that whole power of 0 thing that was being touted actually mean? That is, if you had someone that came in with out of control LDL, would you not treat it? If someone's coming in with chest pain, CAC score 0, would you just say, don't worry about it?
Yeah, so I think, keep in mind that calcium scoring, I think, is best used in the asymptomatic person. I think for CT, for a chest pain patient, I think CT angiography now with maybe some of our additional tools, FFR or plaque quantification may be much better. We don't want to miss a thrombus. We can't see thrombus with a calcium score. We don't want to miss soft plaque or non-calcified plaque, especially in the younger patient. But I think a calcium score of 0 in a person who's above age 45 is still an excellent prognostic marker, and the long-term risk, I'm talking about 10-year risk, is less than 0.1% per year in almost every trial ever done around the world. So I have a lot of confidence, not in the patients with LDLs like Dr. Martin was talking about with 1,000 or 800, I'm going to treat them regardless. But in the patients with moderate abnormalities of LDL or some risk factors like family history, a score of 0 for me gives me great confidence that they don't need a lot of pharmacological therapy, and I can stick to those lifestyle changes that Dr. Fuster talked about.
That's terrific. No, I agree. No one would necessarily advocate a calcium score for someone with active chest pain, but I meant rather if you knew someone had a calcium score a month ago that was 0, and now they're saying, oh, I'm having chest pain. Some have said that you don't really need to be that worried about it, but I mean, I agree with you. Someone that's having chest pain needs more of an evaluation. How about this question? Is there data on fibroblast activation visualized in PET in patients with aortic stenosis? Can the fibrosis of the aortic valve be quantified by that? And I'll just say more broadly, beyond just an echo for the aortic valve, anything more we can do to evaluate it. There's a lot of work, for example, that's been done on calcification and CT and severity of aortic stenosis.
Yeah, so I'm actually, I don't think PET has the spatial resolution to look at the valve leaflets, so I think this might be challenging, although maybe in severe aortic stenosis where you have a really crazy calcified valve, maybe you can see a little bit, but keep in mind the resolution of PET is still somewhat limited. So while we can look at the myocardium, it's not going to get down to thinner or smaller lesions. The same with MRI. We don't use MRI to look at coronary arteries. We tried that decades ago and it failed because of the spatial resolution. If you want to see spatial resolution, we're going to have to look towards CT. And just one last comment, the guidelines, the newest chest pain guidelines, 2021 guidelines for ACC/HA do say that if you have a very low risk patient, and you have with chest pain, and they have a calcium score of 0, that can be useful in guiding your treatment decisions. But certainly acute chest pain, please don't utilize that test.
Yeah, no, those are definitely great guidelines. You're quite right. Well, thanks for bringing us up to date. Wonderful, wonderful talk. Next up, it's